other members who have joined today as the guests. So today's webinar by the Innovative Physicians Forum is on a very important topic. And today, this is the burning topic of today. AI for internists. We all are internists. There are few guests who are not internists from the other specialties. Practical, ethical, and the clinically relevant applications. We have been hearing about this AI, everybody talks about AI, but what exactly this is. And we have three eminent speakers today. They are the life members, academic life members of Innovative Physician Forum. I'm thankful on behalf of the entire executive committee and all members of Innovative Physician Forum to thankful to them for accepting our this request. So the first is Dr. S.V. Kulkarni. And I think most of us know Dr. Kulkarni. He is head of the Department of Medicine, Professor Emeritus, MGM Medical College, Panvel, that is the MGM IHS. He is founder patron of the Doctors AI, founder Dean, Indian College of Artificial Intelligence in Medicine, Executive Editor, Indian Journal of Artificial Intelligence in Medicine, founder, co-chair, Diabetes Technology, Diabetes India, President, Maharashtra Association of Physicians, and founder director, Kulkarni Nursing Home, Center of Excellence for the Metabolic Diseases. And now he will take us through a simple and practical introduction to AI, the artificial intelligence for the internists from concept to clinic, which is the most important. And this will be followed by Dr. Alok Modi and then Dr. Aniket Inamdar. So sir will speak on this topic for next 20 minutes. Please note down your questions in the chat box. Questions will be taken at the last. After three speakers, they finish. And I request everyone to please keep your mobiles on the vibratory mode and this link Zoom in your audio in the mute phase. I welcome Dr. Deepak Jumani. Sir, now the podium is yours. Ashish, please allow Dr. Kulkarni to share his slides, share the screen.
Sir, already given permission.
Can you see my first slide, IPF? You can see the slide?
I can see the slide, but make it in the full.
It is full. For me, it is full.
Okay, then it's okay.
So I'm really grateful to IPF and Dr. Jugalkeshwar Sharma for giving us this opportunity in presenting our very simple, basic, but practical views about AI in healthcare. Our organization is always futuristic and innovative. And I also like to remind all our friends who have joined here that to register for our conference, which is going to take place in Delhi. That's our 8th international event of IPF. I appreciate the way in which he has selected the faculty, that Dr. Alok Modi, Dr. Aniket Inamdar, and a big panel of all the experts who are going to be here. People ask why you want to talk about AI. Very simple and practical question. What is the significance for the Indian physician? I say that it augments your clinical acumen. It is a 21st century stethoscope and a big panel of all the experts who are going to be here. Definitely bridges technology in medicine, but at the same time, our Indian context, it preserves the humanity. Not only we preserve our humanity, we add a lot of empathy with them. ये तो मसाला हो गया मतलब. We have got technology, we have got AI, and we are all good doctors. So definitely it is going to be a good healthcare output for people. Sir, somebody has open his...
Everyone is requested to please keep muted, please.
Please keep muted. So I will not be surprised if our next stethoscope will be something like this with a camera of AI and the stethoscope and everything is attached to this. Why physicians must adopt AI? For that matter, any medical practitioner. Rising patient load in India, huge amount of patients. Sir, there is a concept called as a medical literature doubling time or a knowledge doubling time. In 1950, when the yellow Harrison, which we were reading, that time the knowledge doubling time was 50 years. Now it has gone to few days. We need a precision medicine. I don't want my malignancy person to lose a single hair or not to have a single attack of stomatitis. But what we are getting at the other end, as a caregiver, huge amount of burnout, workflow inefficiency. Then the medical legal pressures are increasing. At the same time, we have got a panacea with us, which is artificial intelligence. I will not call it as an artificial intelligence, it is an augment or assisted intelligence of all our medical professionals, which is going to be a force multiplier. These are the OPDs of everybody. I have got my friends in Sangli, Kolhapur, Satara, who are centurions. Means every day a physician seeing 100 patients is something absolutely phenomenal. But they see it effectively. This is our biggest asset, our patients, and we should try to do best for them. So what AI does for us, it augments our clinical judgment. Previously, in Miraj Medical College and Vandes Hospital, my registrar used to say that if you are getting unequal pulses on one side and other side, and if the patient is having backache, think of dissecting aneurysm of aorta. But here, if you put pulse records on both the sides, the AI clinical paper will give a prompt that think of dissection. Data quality is very critical, where this is the place where we are having lacking. Transparency, we need to avoid bias. Bias, ethics, Aniket, what we're going to talk, that bias awareness needed. We have to ensure patient's privacy, and at the same time, whatsoever you do, physician is the accountable person of every activity when you are using any AI tool. So this diagram you must have seen n number of times. Artificial intelligence is a big capsule. It includes so many things. It includes robo, it includes visual perception called as the computer vision syndrome. It involves natural language processing. Then there is a concept called as the machine learning. But machine learning, it is a linear or logistic regression. And there are lot many other components of that. Let us not go into the detail, random forest and other things. These are the decision trees where we can come down to a conclusion. If you have got 1,000 cats and one tiger in one room, we have to search for 999, but AI picks it for the first time. And deep learning, this you must have heard very frequently, convoluted neural networks and other recurrent neural networks. It is like our brain thinking. A person coming with weakness, whether it is at a muscle level, whether it is at nerve level, or whether it is at the brain level, the way in which we take a neurology long case. So what are the core components? It is called as a machine learning pattern. Then these are all the terms are self-explanatory. Deep learning neural networks, natural language processing in EMR. What way I write my patient's case paper, what Dr. Jugal Kishore writes, or Alok writes, or Ashok Jadhav writes, or Aniket writes, is totally different. But if we want to do a study, and into that we put the PDF of our case paper into that, it will read it by the technology called as a natural language processing. Computer vision imaging, will talk about it, and most important is the generative AI documentation. What do we mean by it? Suppose if you have got a patient of MI to be discharged, you have got the case paper of that patient. Just make a PDF of it, put it to a engine like ChatGPT or and tell him that from Dr. Jugal Kishore Sharma's clinic, this is the discharge summary, your sign, name, everything, all the details will come within few seconds. You can try it once our presentation is over. So just something very brief about machine learning. What it learns from structured clinical data. Predicting cardiovascular risk. I have got a patient's data, height, weight minus height, excess weight, cholesterol, LPA, uric acid, and what it tells me, either probabilities or the risk scores. On the other hand, what deep learning does, it is a neural network for complex data. Example, images, signals. Image, classic CT, MRI, X-ray. Signals, ECG, EEG. And strength, it's got a very high accuracy. But there is a problem of there is a limitation of problem of explainability. This is what is called as a natural language processing. Converts your free text into structural clinical data. For example, OPD, IPD notes to the diagnostic coding. Then in the whole process, what happens in our clinic? There is a electronic medical record or a handwritten medical record. Then you have got labs, you have got imaging. So what the data is done? The data is cleaned and annotated by the model. The model needs development or called as a training. It needs validation, that is accuracy, area under the curve, the sensitivity. At the same time, it should be done with a regulatory approval from CDSCO or FDA, and the clinical integration of EMR monitoring and continuous learning are going to be the very, very important part of our patient care. You might have heard of dozy beds. In those dozy beds, there are signals on the bed itself, and the whole ICU is monitored on a central screen. And immediately the person who is desaturating or who is having severe tachycardia or ECG is likely to show VF or VTAC, the person is guarded and he can go and just check the things at a priority level. So we have got this digital knowledge base. What are the contents? Patient demographic, personal and clinical data, past clinical decisions and outcomes. Suppose if you have got a history of cholecystectomy and if the patient's vitamin D is not increasing, it may give a clue that this person will not be okay with an oral vitamin D. He will require an injectable D. This is how you give the prompt of it. Then this is the analysis with AI. Then possibility of treatment selection. If you write in the history that the patient has got acanthosis nigricans and central obesity, his C peptides are normal, fasting insulin is more. It will, like a tap, it will give a clue that you may use the pioglitazone in this patient. So this is the whole spectrum of deep learning healthcare system. We add data, we add outcome to our knowledge base. The thing synthesizes results from recommendation, and there is some concept called as a CDS, Clinical Decision Support System. This is a discussion of recommendations between the patient, clinician, and our own colleagues, where you can give a good clinical decision and most appropriate or the precise treatment. Some other examples of deep learning applications in healthcare. Precise medicine we talked about. Drug discovery. Previously, the drug discovery used to take about 4 to 5 years. Now it is possible within few months. The protein sequences can be managed. Clinical imaging, everybody knows during COVID time, CT which was done at 10 o'clock, 10:05 used to get the report of it. And very early detection of the disease. The example is tuberculosis, where with a single DNA fragment, you can pick up the infection. And all this, breast cancer, brain tumors, all the malignancies. But don't forget even condition like heart failure. NT-proBNP, don't allow it to raise to 300, 400. Epilepsy, which can be detected with the abnormal signals which are coming from the patient's pre-epileptic form of waves, which can be detected by a model analyzer, which will give signal to 5 people to which they can suggest that this person is likely to have another episode of epilepsy. So just to make it simplified, structured guidance, validated diagnosis, critical notification, information analysis, which heads to your clinical pathway. So what are the diagnostic support tools? You can have a predictive analysis in ICU. Very simple. In a patient of dengue or septicemia, it is not the systolic blood pressure or the diastolic blood pressure, but falling blood pressure is one of the bad indicator of patient getting worsened. Drug safety alerts. I am giving the patient domperidone, azithromycin, then I am adding beta blocker and the patient throws PVCs and I am going amiodarone, I get an alert that this all the drugs are going to increase your QT interval and patient likely to suffer from sudden cardiac deaths. So it indicates guidelines, differential diagnosis support, and what is the ultimate outcome, sir? It is the error reduction for all of us. Medical errors are always carpeted. Nobody has got to tell that, see that with this combination of drugs, my patient might have died. So how the things work? The CDSS can get interface from where mobile text notification, simple mobile, dabba mobile, non-smart mobile, idiot mobile, you can say. But you have got a EHR system dashboard and there are some apps. So these are used for alerts. Not only that, reminders. So many of our patients, they don't consume the medicines in time. The compliance rate is low. And there is something called as the inference engine. So what this inference engine has got? It has got a data knowledge base, patient data, and there is a data management layer. So you can get something like alerts and reminders and recommendations for this patient. Now the question is about data. Suppose you analyze anybody's case paper. It will say that contents are appropriate. Some of them say that it is inappropriate. They are patient relevant and they are not patient relevant. But for me, it is very important to know the allergy. If the patient is allergic to sulfonamides, and if I give the patient sulfonylurea, he's going to land up with a problem. My allergy alert will tell that please be careful before giving this combination to this patient. Same thing for a G6PD. So there are drug reactions not only in the class but out of the class of the pharmacological group also. So from pharmac, let us come to a very important subject of pathology. So a clinician performs a procedure, surgeon, then the original site is evaluated. This is a hepatotoxin eosin scanned image. It goes from one to another. This is an app called as the Path AI. It detects artifacts and it even does a tumor detect analysis. Friends, as a physicians, you might have come across so many patients presented with cannonballs. How you can identify from where the primary is there? So there are people who do boards, who are the board certified pathologists, and they raise the FP tissue selection from the data rich reports. You might be knowing previous few years back there was a Watson database. Now that Watson database has further improved for the medical oncology. Let us come to ECG. For a normal person, it is an otherwise normal ECG. With AI ECG, it has got sinus, not only bradycardia, but a first degree AV block. It can detect WPW syndrome much faster than the naked eye. I get atrial fibrillation. So how my family knows about it? This is a simple watch which can be analyzed. This is called as the peripherals. These are the different kind of peripherals. This can be a Go Key or a Fitbit or the costly versions of Apple Watch. A tumor can be 3D reconstructed so as to decide the planes of dissection, which part the person is then going to take out with a technology called as a cyber knife or gamma knife. So this is a patient's dashboard. Here, this is the way in which the patient flow is monitored and it will tells you how to alert your hospital administration. ICU beds 90% full. There are 3 patients which are flagged at high risk. So this is a way for your administrator to keep a track. This is a very common scenario. Somebody books an appointment, somebody cancels, they need it again. So this you all go by a chatbot. My friend Dr. G.S. Kulkarni from Miraj Sangli, he has got a chatbot which talks in Marathi, English, Kannada, and they take a very simple way of doing the appointments. So when you have got running a hospital, everybody of us is running an office and as well. So there are administrative jobs, appointment, billing, OPD counter, IPD, lab, sample headlines, printing, financial accounting, payroll, and inventory and stock. Nobody should tell you that at 2:30 in the morning, my stock of tenecteplase is exhausted and I got a patient of stroke who doesn't show hemorrhage. He needs tenecteplase urgently. So AI can help you definitely in a much better way. Please, God's sake, don't mix up many matrices. This is a hypoglycemia detector. Keep it as a hypoglycemia detector only. Don't add a BP parameter to me. All our non-communicable diseases are gold mines for research. So this is what was 2024 and what we are going to expect with a CAGR of 10.6%. Tell me who is giving you 10.6? By the technology is also increasing for diagnostic devices, glucose monitoring devices, and others. What is the other? Your urinary microalbumin. Just put a strip. A QR code will come. To scan the QR code, send it to the lab. It will tell you how is the urinary microalbumin. No doubt, TB must be driven. I got a friend. His name is Dr. Deshpande. He runs an organization called as the Rises AI. And see even the slogans. TB 100% अच्छा होता है, ट्रीटमेंट जल्दी करो. TB हारेगा, देश जीतेगा. So these are the AI generated art, your productivity things. You can see the X-rays. Not only see a single, but you can see the multiple things. Here you can see the nodules, and the patient here you can see a pneumothorax. Suppose if this X-ray is not trained for surgical emphysema, it will tell you that I have not understood this. Yeah. So this is our data collection, AI model development. Then these different lung regions are calculated, and it tells you that there is a tuberculosis in the left upper zone, this particular segment. It detects as well as excludes. So there are 68% abnormalities, 47% low lung opacity and nodule, but there is no effusion, there is no mass, there is no pulmonary edema, there is no cardiomegaly. Very nice for a clinician. It looks beyond your eyes. The pleural effusion, which is not detected in the CCG, is detected by the AI technology here. So, last few slides, whenever you want to understand and how to train data, please define your objective. Suppose if you want to do some research in diabetes or thyroid, conduct a system and workflow assessment. Focus on the user-centered design. It should be simple that your staff also should be in a position to fill. Use the right development path. Keep it very simple. Even an Excel sheet also will help. Then you integrate, test, and the compliance checks. So what is at the end scale? You have to scale it, you have to train it, and don't forget, you have to improve continuously. This is a field where within one day, the data can be obsolete. So this is what you standard get from EHR, then you do NLP, there is a structured data like with prediction, classification, clustering, and finally you get a outcome. You can add something more, and that is what? Variables. You might have heard a concept called as a big data. The big data is actually internet of medical things. Huge amount of data are there. These are the various machine learning models. What is it? Supervised learning, unsupervised learning, federated learning. Just to tell you something very simple, AI learns from its own mistakes. So it is not like, our juniors or our colleagues who don't want to accept their mistakes. It learns. So if you have got one person's medical data, it is some few exabytes. And that is 1 million terabytes. And see here the amount of data which is going to be collected in 2025. It was something like 11 zettabytes. It is used to store big medical data for research and publications. A CDSS is a multimodal input analysis. You can put everything. You can other specialties opinion, new prescription, drug interactions, history, lab studies, imaging studies, medication list, and it will give a AI suggested clinical decision support system. My plea to all of you is please keep records in a digital format. A very, very humble request. It is even though it is unstructured data, you can use NLP. With the structured data, you can extract, you can clarify, you can train the analysis, and you can summarize. These are all the utilities which are going to ultimately increase your AI enhanced practice. There are lot many references. We are going to be in touch with Dr. Jugal, and I will be sharing you some still more references. There is one journal called as the New England Journal of Medicine on is called as the NEGM AI. We are also coming out with a journal which is called as the International Journal of Artificial Intelligence in Medicine. I, being the executive editor, I request all of you to contribute for that journal. So, friends, at the end, it is the balance which is more important. People say that AI is going to make you dull, idiot, and you will be dependent upon machinery. No. Yes. It is going to increase our efficiency, personalize the treatment, cause faster diagnosis. But what Alok and Aniket are going to talk about is AI, the bias risk, trusting issues, unequal outcomes, and the amplified bias. So we have to balance the promise as well as peril of AI in healthcare. This is what I wanted to just show you in the decided amount of time. And now we are going to have more amount of discussion after you listen to Alok and Aniket. And I'll tell you, they are wonderful speakers. They have got huge amount of knowledge, and they are going to enrich still further than what I told you about.
Dr. Kulkarni, thank you very much. Please introduce Dr. Alok Gupta. Alok Modi, yourself. You please introduce him and invite him also.
Dr. Alok Modi is a really big name in the field of AI.
Kulkarni sir, yes. Just a minute.
Yeah.
Actually, Alok sir is attending one emergency, so I will take the next talk, and then Alok sir will take at the end.
Okay, no problem. Alok is always multimodal. I know he has got 3-4 screens open at one time. So I'm really proud to have Aniket with us. Aniket and me, I have got one similarity. We work in a place of Maharashtra which are not even district taluka places. Forget about district. He works in a place called Umarga. I started practice in place called Khopoli, which is in between Mumbai and Pune. And tomorrow you are going to get the great missing link open for my place towards Pune. And Aniket, I am very proud of you for one very simple reason. You are a solo fighter. You are collecting data, you are representing. In ACP, he got a very good award for it. And Aniket, please share your views, your ideas, and let us keep the things in a very, very good interactive way.
But before Dr. Aniket starts his presentation, I would like Dr. Sen Gupta. Dr. Sen Gupta is President of Innovative Fusion Forum. To please welcome everyone and say only 2 lines. Dr. Sen Gupta, are you around? Dr. Sen, he has already put a message for me. So anyway, if he's not there, no problem. But Dr. Kulkarni, please don't say that you all people 3 are from Maharashtra. So we say that it is Maharashtra. No, it is Innovative
sir.
Fusion Forum with an international.
There
It's an international forum now.
There are pan-India people who are working in small place. I had been to Batinda. I have seen how Dr. Vitul Gupta works. I've been a very compassionate attending of his all the MapCons, and the way in which he gathers people from all over the country. It is not. Yes. Thank you.
Yes, sir. Thank Please allow him.
Sir, is my screen visible?
Yes. Yes.
Yeah, thank you, Sharma sir, and thank you, Kulkarni sir, for the kind introduction. Now I am here to enlighten you about the ethical, safe, and responsible use of artificial intelligence for physicians.
Just a second, please. Everyone, please mute yourself. Dr. Rahul, please mute yourself. Thank you.
Yeah. Now we know we are in the era of artificial intelligence, and it is rapidly changing the way we practice medicine. So AI is transforming the healthcare at an unprecedented pace, from diagnostics to the clinical decision support, as very well explained by Dr. Kulkarni sir. These artificial intelligence systems promise enhanced accuracy, efficiency, and patient outcomes. However, with the use of more and more AI in clinical medicine, this rapid adoption definitely demands careful scrutiny and responsible implementation. A recent report by WHO in 2025 says that AI driven diagnostic tools will be integrated into 70% of the healthcare facilities worldwide. And this rapid expansion definitely raises some critical questions. How do we ensure these systems are safe? How do we identify and mitigate the inherent biases that I will talk about in the latest slides? And most importantly, how do we maintain the human element in patient care? And this is the one of the most fundamental issues that AI is facing today. So it is our responsibility to extend beyond simply adopting this new technology. This We have to embrace this technology, but we must become an informed stewards of artificial intelligence, understanding both its capabilities and limitations to ultimately benefit the patients. Sir has very well explained the rapid adoption of AI. You just see the amount of phenomenal growth that AI is having in medicine. In 2023, 38% of the physicians used AI, whereas in 2024, the percentage went up to 66%. I will take you to the other side of the artificial intelligence adoption. There are certain risk and governance issues that are still there, and we need to be very, very vigilant about this. Only 16% of the health systems have AI governance policies. So there is huge gap where the governance is still not there, and significant lack of these comprehensive policies puts institutions at risk. There are 92% of the healthcare organizations have already reported AI related attacks, especially the cyber attacks in 2024. The malpractice, especially the AI related malpractice claims, have been continuously rising and rising. And global leaders do have concerns. Like 87% of the people still worried about the AI data biases worsening the health disparities. So we need to understand its limitations also to ensure the patient safety and optimal clinical outcomes. So we need the training data dependency. There is a problem of black box that I will explain you, and the static knowledge base that some of the systems in artificial intelligence development do use right now. So AI performance is constrained by the quality, diversity, and representativeness of the training data. Some models are poorly trained on some particular populations, and we cannot extrapolate those models to the whole diverse amount of population. So models trained on limited populations may perform poorly in a diverse clinical settings. And what is black box problem? Black box problem is there in artificial intelligence because still many of the large language models do not tell us how they arrived at particular recommendation or particular decision. So it is very difficult to understand specific recommendations when they are generated by the large language models. So if we want to identify the errors, how can we identify if the AI is not giving us how it came to that particular conclusion? Unless you know the thought process, how it came to that particular conclusion, so it is very difficult to identify the problem and correct it. Now, many solutions are coming up, but most of the large language models that we use in our day to day practice still have the black box problem. And unlike human physicians who continuously train themselves, learn new things, some of the AI systems still require retraining to incorporate new medical knowledge, potentially leading to outdated recommendations. And one of the critical findings that was shown in 2023 JAMA study that 60%, 68% of the AI diagnostic errors still stem from the training data biases. So, what are the key limitations of AI in healthcare? The recent 2026 LinkedIn review of the clinic AI found that most of the so-called confident models still misfire on scattered EHR data. 2026 analysis identifies the fragmented patient data across EHR labs and portals as a primary failure point, and it causes 80% of the incorrect medical summaries due to timeline errors. There are operational gaps which still persist. The 2026, the recent one, World Economic Forum has said that why AI tools fail clinically because of the gaps that are still persisting in operationality of the AI models. In the primary care settings where most of us are internists, over reliance erodes the judgment without clinical human oversight. So you cannot use the all systems without the human in the loop. Ultimately, it is the human mind which will take the guidance from the artificial intelligence given recommendations and take the decision which will benefit the patient. So why the confident AI models can be dangerous? Because the data is fragmented, the context is fragmented from different EHRs, labs, and insurance companies. There is automation bias is there, and data noise is huge because of typos, error, different units of measurement. So there is not a uniformity of the AI models being trained. So if the AI model is getting trained on these biases, then how that model will be operationally efficient? It will say that it is confident, but ultimately it will not improve the patient outcome. It will fail. So what is the foundation of success? When we develop an AI model, especially the large language model in healthcare setup, it needs to have certain pillars. So that should be the foundation. If the foundation is not good, the project is going to fail. So what are the foundations? It needs to have the common clinical definitions in hospital, clinic, labs, everywhere. The common clinical definitions must be there. Uniformity must be there. There must be reliable chronology. Most of the AI models still fail because AI must separate when the event happened from when it was documented. These timeline errors cause 80% of the incorrect medical summaries and lead to false recommendations, and interoperability challenges still present in different models. So let us understand what are the biases in artificial intelligence systems. There is a racial bias, gender bias, and age bias. I will take you some of the examples. One of the study which was published in JAMA, where it showed that algorithmic skin cancer detection showed 34% lower accuracy for darker skin tones because the training data model didn't take account of black population. So it was a racial bias. Coming to the gender bias, the cardiac risk production models underdiagnosed women by 28%, such a huge amount, to male dominated training data. Why? They didn't use the gender properly, so it was not extrapolated. So again, this was a study from Nature Medicine. Again, age bias, frailty assessment algorithms perform poorly in elderly populations because of atypical presentations. So these examples tell us that the training data imbalances propagate through AI systems create disparity in patient quality, ultimately in care quality. There are some diagnostic errors when we implement AI in assisted care. AI systems may generate false positive or negative, particularly when encountering rare presentations. So when you put some kind of rare presentations to any large language model, there is a high chance that it will give you the wrong diagnosis or wrong recommendation. A 2024 Lancet Digital Health study documented 12% higher error rates in AI diagnosis for minority populations. Again, because of poor training data. Alert fatigue, over reliance on AI generated alerts can desensitize clinicians. And I highly recommend our esteemed team here because artificial intelligence is artificial. We need to have this human intelligence to interpret this artificial intelligence and not to deteriorate our own intelligence. So that is one of the most important thing to be careful about in this era of artificial intelligence. And some technical malfunctions or some cyber attacks can disrupt the AI, leading to poor recommendations. So there are certain risks in clinical AI implementations. Over reliance because of the automation bias, which will lead to the decreased clinical vigilance and critical thinking. I don't want any of us to reduce our frontotemporal cortex area because of less critical thinking, because of overuse of AI. So one side you use AI, but do not stop thinking on your own. That is one of the biggest asset that we have. And the second, context failure. Algorithms perform poorly when we apply them outside of the training conditions. Accuracy drift, we always notice that performance degradation over the time, because clinical practice evolves, medicine evolves, evolve. So whenever these happens, that model needs to be trained accordingly. If the model is not getting trained in the real time, it will provide poor outcome. Understanding these risks enables the proactive mitigation strategies, and it will help us to make an informed decision about the AI system adoption. So there are some ethical considerations while navigating the landscape of AI. So we have to maintain the patient autonomy while leveraging AI recommendations. Patients' data needs to be anonymized, because without that, we cannot have this ethical implementation of AI. Beneficence should be there. First policy we should implement, we do not harm. It should be the first policy in implementation of AI also. And we have to ensure equitable access and fair treatment across all populations. So what we need is deployment of ethical AI, which requires balancing innovation and patient welfare, as rightly said by Dr. Kulkarni sir. A recent 2023 American Medical Association guidelines strictly emphasize that it is the physician's responsibility to take the final call, to take the final clinical decision, regardless of AI recommendations. Not the AI. It is not the AI which is going to take the final decision. It is the clinician who, on the basis of AI and his own clinical judgment, will take the clinical decision and change the patient outcome. Clinicians must maintain appropriate skepticism and exercise independent clinical judgment. So this is, we need to be very, very careful in this era of AI. So what are the risks? As we said earlier, there are data breaches because of AI processes. Vast amount of data, sensitive data is at the risk of cyber attacks. AI systems vulnerabilities are there because of hackers, and everybody knows how to. They are now using AI to hack systems. So AI is helping good people also. AI is helping bad people also to do the bad things. Ransomware attacks, ransomware risks can paralyze the AI systems. Data anonymization should be there. Anonymized patient data can still be re-identified, compromising policy, and which we can do with this help of AI also. So this anonymity should be strictly followed. Consent and data ownership, we must understand that who is the ultimate owner of the data, of the patient's data, that needs to be clarified in the governance policies. So data privacy and security is again very, very important challenge. In 2023, Health Information and Management Systems Society report has clearly documented that 45% of the increase in healthcare data breaches involving AI systems. And you know how much people have been affected because of this? 18 million patient records have been already affected. Last year, one of the cyber attack on Indian system also have exposed that data breaches are happening in India also. So what practices we need to follow? We need to implement end-to-end encryption of the all patient data, establish strict controls and authentication of protocols, conduct regular security audits. We have to strictly follow the GDPR and HIPAA guidelines, and we have to develop our own Indian recommendations and regulations that we are closely watching and developing, and develop incident response plans and data breaches so that we can avoid it. AI, with the help of AI, there is now manipulation and addiction also. So now exploitation of health anxieties, misleading health information is there with the help of AI. And we are at the brink of addiction, because we are too much using ChatGPT, Perplexity, and so many AI models. So we are over relying on health tracking apps. We are in an unhealthy obsession of the health data. So this unhealthy obsession is creating dopamine surge and putting at risk of serious addictions. And we all know that patient doctor relationship is already getting deteriorated, and AI puts huge problems on this already deteriorating relationships. So sometimes patients use AI to challenge the doctors. So this is one of the again serious problem. and reduced human interactions, because a lot of people now are using chatbots and so many things. So there is a less and less human interaction which is happening today, and that is again worsening the doctor patient relationship. Impact on labor, we all know that AI driven automation is expected to lead to loss of at least 300 million jobs, including healthcare. And there is a carbon and water footprint of LLM also, because development of LLMs requires huge amount of energy for training and huge amount of water also. So how do we address this algorithmic bias in healthcare artificial intelligence? We need to ensure that AI models are trained on representative data sets encompassing varied demographies, geographies, and socioeconomic backgrounds to prevent the biased predictions. We need to rigorously validate these protocols, these AI models before deployment, documenting performance metrics for each subgroup to identify the disparities. And we need to continuously monitor these performance of these AI models in real world settings so that they will give you accurate predictions and uh, models that will correct the emerging biases during the clinical use. So we need to design and validate all the AI models across diverse populations, and that is the need of the hours. We need to use these FAIR principles where we store the data and metadata. We access the data, metadata are retrievable by the identified using standardized communication protocols. We need to improve the interoperability by using so many vocabularies and qualified data references. And ultimately, we need to reuse the data and metadata where sources can be easily shared along with the different methodologies. So we need to ensure highest amount of standard while using the artificial intelligence in clinical medicine. So how can we do that? We have to target the accuracy rate of 95.2%. That should be the minimal acceptable diagnostic accuracy for AI systems in high-stake clinical decisions. Without that, we cannot compromise our patient's clinical outcome. And acceptable error margin, only 15%. Maximum tolerable increase in error rate compared to the standard clinical practice. What is the system uptime? 99.9%. And what is the audit frequency? Regular interval for comprehensive performance evaluation should be done within 30 days. These should be the highest standards of benchmarks that should be established during AI system validation and monitored continuously during the deployment. So how can we do that? How can we manage the AI risk in healthcare? We can use this 4-step framework where we need to identify the AI risk by creating inventories, all AI systems, map data, and evaluate the integration points, apply the FAIR strategy that I just discussed, classify AI tools by the autonomy level. We have to keep multi-layer security systems and encrypt each and every data that we have, maintain the human in the loop oversight. We just cannot escape this step, and always monitor AI system behavior continuously. With these actions and establishment of the proper governance, we can reduce the black box warnings, we can reduce the hallucinations and improve the patient clinical outcome. So how can we improve the safe AI adoption? By validating across all populations, using transparent systems, by keeping the human in the loop, that is to maintain the clinical judgment as a final authority. AI provides just clinical support, not autonomous decisions. So AI is there to assist us, not to replace us. That is the dictum that we must follow. We should ongoing continuously monitor these models, and we always have to accept the ethical review, which is regular, time-bound ethical review, which will be implemented on an institutional basis to use these strategies on a worldwide scale. So biases mitigation should be done, diverse funding should be there for monitoring and evaluation, ethical use should be there, lot of ethical standards, regulatory compliance, and transparent algorithms should be used. There are 2 guidelines and recommendations that we must follow. In Europe, they use EDPR guidelines, whereas in US, they use HIPAA guidelines. So these recommendations, these acts should be accepted worldwide. Even India is developing its own AI standards and regulations. So whenever we have that kind of recommendations and good governance practices, we must implement it. We must regularly monitor it. So as Kulkarni sir has said rightly, that AI is there to improve the patient outcomes. 62% reduction in diagnostic errors can be done with the help of AI. Time saving is there. 28% we can reduce the time in documentation. But there is a disparity. If there is a disparity, unvalidated AI systems have been showing that 3.4 times higher error rates in minority populations if we do not diversify the AI models while they are being trained. So AI is useful, but if it not properly trained, properly monitored, ethically accepted, and safely monitored, it can be devastating too. So we need to balance it with the help of proper innovation and proper safety proposals that we need to follow the HIPAA guidelines and EDPR guidelines. So what are the pillars of responsible AI adopt implementation? Rigorous validation should be there across diverse populations. Clinical collaboration should be there in researchers, IT people, healthcare workers, nursing people, even data analysts, data scientists. So safety should be the utmost priority when we are dealing with the clinical judgment, and fairness monitoring should be there, and continuous learning should be the uh, pillar of this AI adoption. FDA is doing great work in AI-enabled medical devices. A lot of ethical standards have been placed by FDA, and the recent one is January 6, 2025, continuously monitoring the how artificial intelligence-enabled devices, software functions, life cycle management, and marketing submission recommendations have come up. And what they are telling us that this is a significant publication which continues to demonstrate that FDA's efforts to provide transparency and also ensures product safety and effectiveness while supporting the innovation in this rapidly growing field. So this is the implementation roadmap. We need to evaluate properly. We need to have diverse populations, validate accordingly. We need to integrate while workflow mapping, IT structure. We need to use it in a pilot projects and then full deployment across the populations for a clinical use. So evaluate the clinical need, assess the regulatory status, engage with different stakeholders, train the clinical staff while using AI, and continuously monitor and audit these things. So what are the key takeaways? A call for the action. We have to maintain the clinical oversight. AI is just to help us, not to replace us. AI is not going to replace the human judgment, physician's judgment. That is the ultimate. Who is taking the ultimate call to improve the patient outcome. So always exercise independent clinical decision making and remain ultimately responsible in the patient care. Understand systems limitations because AI can have so many issues, as I said earlier. So we need to understand its limitations. We need to prioritize the patient's privacy by anonymizing data, using encryption, and we have to champion equity by advocating for diverse training data and rigorous biases and testing to ensure the AI systems that serves all patient populations fairly. So validate rigorously, monitor continuously, and always maintain the human expertise that remains irreplaceable. So what we can do as a physicians, we have to establish institutional AI review committees, implement standardized evaluation frameworks, and prioritize transparency in vendor selection. The future of AI depends on our own collective commitment to a responsible adoption. Today is Narasimha Jayanti, and in Maharashtra, throughout India, in South India especially, we celebrate this with a great devotion. So I bow down to Prahlada and Lord Narasimha. My salutations to Narasimha, who blessed Prahlada, who is the consort of Lakshmi, the slaver of the king of demons. And I thank Dr. Jugal Kishore Sharma sir, SP Kulkarni sir, for giving me this opportunity. And let us use AI, embrace this technology, but not let us replace the human judgment with the artificial judgment. Thank you for patient listening.
Thank you so much, Dr. Aniket. That was a wonderful presentation and a very beautiful insight into the world of AI and something which is very, very important to all of us. Our next eminent speaker is Dr. Alok Modi, eminent senior consultant physician from Thane. Dr. Alok Modi needs no introduction. He's got special interest in diabetes. I've heard so many times him speaking about AI as well. So over to you, Dr. Alok Modi, and we can take questions together after that.
Sure, sure. Thank you, Puneet sir. And at the outset, I would like to give my humble thanks and regards to GK sir for this wonderful creation. And the whole idea was floated between us, and sir said we should do this. So I'm very grateful to him for taking up this initiative. I would also like to offer my regards and respect to all the dignitaries who are present on the virtual dais here. My respects to all of you, and I would like to apologize. I was supposed to take the second talk, but then there was a chest pain, and I had to comfortable relative, so I got a little late. So now what I will do is I'll do something here different because Kulkarni sir, and thank you Kulkarni sir for those wonderful words of appreciation. Thank you Aniket for those nice words. They have actually covered the whole ecosystem very beautifully. So a lot of work has already been done. So what I will do is I'll cover some real life examples. The proof of the pudding is in eating it. So we have spoken a lot of theory. Let me show you in real life where AI is deployed in real life and how it is working and what advantage it is giving. And I will not come with only Western data because we are living in India, we are interested in Indian data. So I'll show you real life evidence of Indian data also. And I'll hurry up through that because I think what's more required here is most people think AI is something glamorous. It's like a magic wand ki kuch to ho jata hai aur fir kuch naya kachra karke jata hai. Then we are scared of that. So we need to look into that. But I'm giving a talk. I'll talk to you later. So I'll talk. I'll take 5 minutes. I'll explain to you. Actually, ये काम कैसे करता है? You buy a Mercedes or you buy an Audi. You want to know what is under the engine. ऐसा इसमें क्या great है? That should spend 1 CR or something to buy that car. So let me go into that. So let me just share my slides first. I'll start with the presentation here, which is my presentation once again. Just give me a minute. A lot of presentations.
So Rajesh, please allow Dr. Alok to share his slides, share his screen.
Sir, already co-host.
Yes, yes, sir. दिया है उन्होंने. Second. So I guess my screen is visible now.
Yes.
Yeah, sir. It's visible. Yes, sir. It's visible, sir.
So I'm just coming out with 25 actual evidence-based examples in real life. मैं वो दिखाता हूँ, then we will talk something else after that. So this is the sepsis model. So I'm not going to talk any theory. I'm showing you actual real life implemented work going on in various hospitals. So this is the AI sepsis model. This is the composer model. This was deployed in US in San Diego in 2022. What was the benefit of using this model compared to what was a standard of care in the ICU in 2022 and before in those hospitals? There's a reduction in mortality by 17%. And this is a sepsis prediction. So what happens is, bottom line is very simple. When patients walk into the ICU, they're not in sepsis or they're in early sepsis. The question is, will they go into sepsis? Question is, will they die? And how do we prevent deaths and how do we prevent them from going into sepsis? So that thing was handled by AI. As you all know, no other technology in the world can do prediction. Only AI can do predicting. So for example, let's say your clinic has got 500 patients. And out of that, let's say 300 of them do not have diabetes, do not have blood pressure. Now, I'll ask you a question. If you're really a great clinician, after 5 years out of those 300, how many will develop diabetes? Or I'll ask you a better question. How many of them will develop pre-diabetes and how many of them will develop pre-hypertension? I know there's nothing like pre-hypertension. So they are normotensive, they are non-diabetics. They're not even pre-diabetics, but they will develop. Can they be predicted? ये क्या astrology का हम कर रहे हैं? AI can actually predict. And how does it predict? It uses variables like lifestyle, ethnicity, food habits, and all that. So they do not have any background right now, but they can develop, and this is shown to be statistically true. So this is what is important, and this is something which needs to understand. And having understood this, you will start respecting AI. AI changes the tables very drastically. So here in this thing model, people who walked into the ICU are not destined to die. They are not destined to develop sepsis, but 17% mortality was reduced because of this. And these are the actual case studies and the actual references that I'm showing you, so that can be understood. What about FDA authorized AI sepsis diagnostic tools? Now, here, The first FDA authorized AI diagnostic tool by the de novo pathway was launched in April 2024, and it integrated 22 parameters. Now, see, what's important here is we are integrating parameters like CRP, procalcitonin, lack of oxygen saturation, drop in the blood pressure, etc. So we do not have a huge chunk of parameters. Here they have integrated 22 parameters. And if I'll deviate from the topic here, when I was in Chennai a few months back, Rajiv Chawla sir had asked me to give a talk on AI markers in the diagnostics and predictions of gestational diabetes. And when I reviewed the literature, I was amazed to find out that how we diagnose gestational diabetes by doing a post lunch as per the DIPSI guidelines. And we generally pick it up in the second trimester. AI is using 230 variables. Can you imagine that? 130 to 230 variables and more than 5 million meta-analytic database, and they are able to pick up GADM in the first trimester, and they're able to reduce the neonatal and the maternal morbidity and mortality by as much as 10 to 15%. That is what is the power of AI. And this FDA approved sepsis diagnostic tools can be embedded into whatever EHR you're doing. You don't have to have a special EHR. And naturally, the ICU transfer rate, the mechanical ventilation onboarding, and the vasopressor use is drastically reduced and cut down. So that's the real life which is going on right now and is being used in real life. Another tool, the TRIUS sepsis alert system at John Hopkins Hospital. This has been deployed across 5 John Hopkins Hospital over 2 years. And they are picking up real-time sepsis detection and early warning. So what happens is patients who are admitted and are going on and are taking treatment, when somebody in the medical ward, when somebody in the surgical ward, when somebody in the ICU is getting propensated to go into sepsis, are the people who would be live taken up. So, suddenly you'll have a warning that so and so patient is fine. He's not in sepsis, but he is destined to go into sepsis tomorrow. So, once you're aware of that, you can obviously reduce the morbidity and the mortality. And this is a retrospective analysis of 9,800 confirmed sepsis cases by this TRIUS technology. And it identified 82% of patients before they actually deteriorated clinically. And this they have emphasized very clearly, like Dr. Aniket said, that is not the algorithm which is doing the work. It is a human AI collaboration which is giving you an actual benefit. It is not just an AI which is giving a benefit. So it's a partnership of the clinician and the AI. So these are some real life examples which are mind boggling, which I thought I'll show you. Now look at the COVID-19 ICU mortality prediction. The Massachusetts program in General Birmingham has analyzed 10,826 COVID-19 patients, and they found that and they're not using one algorithm, they're using 18 different kinds of algorithms, and they're working in tandem. And by doing that, they could compare it, and this is a respectable study, because you're looking at 10,826 parameters. And they found out that in these patients, the oxygen requirements, the age of the patient, and CRP and ferritin and D-dimer were the markers which could predict the complications of mortality and morbidity in COVID-19. And they did it by a method which is called as logistic regression. I've already taken statistical talks in the past in various conferences on different statistical analytics of AI. Maybe if JK sir permits, we can take it next time. But logistic regression is a very fantastic AI tool which is not present in the conventional statistical model. It makes a huge amount of difference. When you review certain original manuscripts, the outcomes are very different. Let me go to something else. This is also present in India. I think it has not walked in completely, but the Cardia device in India, I think they've started using it. But this is a device which is from the US. This is an AI fibrillation detector. And let me make it clear here, the Apple Watch does not pick up AF. If it picks up AF, these smartwatches of any company, I would not like to take names in a public forum, are not authorized and approved by authorities that they can pick up FDA. But this is a Cardia mobile. I think Dr. Kulkarni sir had shown it once. This is a mobile which can use only 2 thumbs. So you just put 2 thumbs on the hardware, and it can pick up an atrial fibrillation going on in a patient who may be asymptomatic and who may be doing very well. And this prediction is running at a sensitivity of 88.4%, which I don't think is very high, but that is the reality because we're showing you actual data, and the specificity is 98.8%, which is important. So what's important is that the AF is a true AF. It's a pretty high specificity. And this is very good because this can be launched in all your hypertensives, diabetics, elderly people, high risk populations. And you can pick up AF before it actually creates a patient to land up in the emergency room in a critical condition. So this is another real-time application of AI in internal medicine. What about hypertension? Now you'll wonder, how does AI help in hypertension? So I'll just say a few words here. So normally what happens is we do a lot of ABPM. Now why do we do an ABPM? We do an ABPM because what is important in an ABPM is that, once again, just let me disable this to uh, yeah. We get different kind of blood pressures, which are, white collar hypertension, masked hypertension. I won't go into those details. Yeah, when we were students, we were told that white collar hypertension is a physiological knee-jerk reaction because of anxiety. It is not to be treated. The current guidelines are very clear. Any kind of hypertension needs to be treated, whether it is masked or white collar or whatever. The problem is you get a lot of hypertension heights. You don't come to know whether the person who's dipping, is he a good dipper or is he a bad dipper? You don't come to know whether the nocturnal hypertension is prominent and daytime is. So, a normal blood pressure recording in a patient's home as well as in your clinic can never pick up nocturnal hypertension. So these are something which ABIM pick up. Now, when you're doing a 3-day or a 2-day ABIM, can you predict that this person who's a non-hypertensive will become a hypertensive? Can you predict that this hypertensive would need 3-drug therapy or 2-drug therapy, or will become a refractory hypertensive? These are the questions which you cannot answer even if you're doing an ABPM. And here the design is such that you can take a clinical decision support system. It helps you taking a clinical decision as to what you would do with your so-called non-hypertensive or nocturnal hypertensive or early hypertensive, and how you can predict that whether your medicines will actually work and help your patients improve. So what happens is, if you put a person on 1 drug or 2 drug, how does he respond after 6 months or 1 year? Those prediction outcomes can be done by this system. That's why it's called as a CDSS, Clinical Decision Support System. And this is a fantastic tool. It works very well for resource poor primary care settings. So people who are running simple clinics like Asha Bai workers and other people can use this system in the rural healthcare where you don't get many doctors and you don't need a highly qualified doctors. And these can be collaborated and converted and collaborated with top-notch cardiologists and physicians in metro cities, and the outcome can be given. So this is another use, and this just needs a smartphone, nothing else, a plain simple standard smartphone. You don't need a high-powered hardware on this. So this is an AI-assisted clinical decision support system for both hypertension and diabetes in that track model. And this has been working under the Ayushman Bharat scheme in AIIMS New Delhi, and it's in partnership with the Emory University. So basically what happens is this collaboration is taking care of this CDSS and the current guidelines, the Indian Hypertension Society guidelines, which were just released. And I'm grateful to the entire team of Indian Society of Hypertension for giving me an opportunity. I've also written a chapter on the technological part of Indian Society of Hypertension guidelines. And these guidelines can be incorporated in the CDSS and decisions can be changed. So the beauty of this AI systems are, if you're given the training on the AI model, like Dr. Aniket said, on let's say 25,000 patients with the current set of guidelines, you can always retrain the same model with a different set of guideline and give a much better outcome. So everything is in your hand. It doesn't need a lot of money and expenditure, but the model can be retrained multiple times to give you a much better outcome. Now, important part is we have always learned that Indian patients are always in a postprandial state, right? We have heard a lot of seniors telling us that Indians are always eating and eating, and they are always in a postprandial state. And we know that the type 2 diabetic in India phenotype is more of a postprandial phenotype. And we know that maximum complications occur because of postprandial hyperglycemia and not fasting hyperglycemia. So when you adopt machine learning for postprandial glycemic response in an Indian phenotype of type 2, they did this in 14 outpatient diabetic clinics, and they picked up a huge chunk of patients in 14 sites. And this kind of a response was analyzed by machine learning, and they could give prescriptions on a precision level, personalized level, to tell individual patient where there is a gap between the doctor's prescription and the outcome on the patient. So this is important because what you can do with machine learning is you can give precision medicine prescription. So in your own clinic, if you're writing 3 drugs for a postprandial hyperglycemia, those drugs will change patient to patient, because your AI tool will guide you and tell you this patient needs probably more of Voglibus and this patient probably needs more of metformin or whatever. Just giving you a rough example. So these AI tools can analyze the pattern of the patient and give you a better deployment of your prescription. Google ARDA, one of the most fantastic and respected tools for picking up diabetic retinopathy. Where is it working? In India, in the Aravinda Hospital, at 45 sites in India and southern India, more than 60 lakh patients screened. Published in JAMA Network very recently, the Open Network 2025, 600 million patients screened across 45 sites. And what do you get? You get a huge global significance of picking up retinopathy with sensitivity and specificity running from 98 to 99%. This is the reference, as you can see. So what happens is one ophthalmologist can scan one patient, right? So here you can scan maybe 50 patients through a standard smartphone with a standard camera and deploy the AI tool which is created by Google ARDA, and you can pick up a mass presence of proliferative and non-proliferative retinopathy, including your own clinic. So the turnout time gets reduced and the sensitivity specificity being high, the primary care level care becomes extremely high. Now, this is another Remedio AI, another respected tool for diabetic retinopathy, again also being used in Shankara Netralaya as a point of care DI deployment. AI deployment, 9 trials, prospective study 2017 to 2024, deployed by 50 workers. So 50 trained healthcare workers were deployed at the same time, and so much of patient data can be collected. So you can create a lot of research, you can do a lot of analysis, you can give actual real-time care to your patients without putting in a lot of money in the hardware. So I think Kulkarni sir talked about this. The Cure AI for tuberculosis detection, the pickup rate is extremely high. QXR is also being used in Nanavati Hospital in Mumbai. It's published in an open forum infectious diseases journal in 2026, this year itself. And they have shown significant pickup of tuberculosis. So you don't have to do a Mantoux test, you don't have to do any kind of sputum test, and etc., etc., etc. You just take up the X-ray and you can pick up tuberculosis, which a doctor may or may not pick up. So that's something very important. So if you were to listen to Dr. Gune, who had taken a class on this, he's a esteemed radiologist from Mumbai, and he said that the triaging works well. So what happens is a radiologist gets 500 X-rays, let's say, and he has to pick up from 500 X-rays. So AI can scan those 500 X-rays and tell the radiologist that 450 are normal, you don't bother. These 50 of them could have suspected tuberculosis. It looks at mediastinal fat, can tell you these are potential pre-diabetics, these are potential MIFID patients. It can give you all those analyses, which are comparable to a MIFID analysis from a hepatic fat analysis, and can tell your radiologist to focus more on these X-rays. The others are normal, don't waste your time on them. So one, the radiologist earns more money, he gets more time for his family and his wife and his children and to enjoy. And three, the patient gets more benefit because the pickup rate is high, the turnover time is very high. And six, very cheap, very affordable, very much workable, and actually being worked in India. And Cure AI was also being used in COVID. So this is an autonomous chest X-ray analysis system. It has been trained in 5 million X-rays. So the sensitivity specificity is very, very, very high. And the beauty of it is 30% of radiologic abnormalities, which are undetected by radiologists, are getting picked up by this thing. And not only TB, it can pick up pneumonia, nodules, pleural effusion, cardiomegaly. I just spoke to you. It can pick up many things which has not been picked up so far. So obviously, you can launch it in public hospitals. You can launch it in various programs and health schemes and screening methods. And I can go on and on. You can go through the reference. Benefits are huge over here. What about AI for chronic kidney disease prediction? So we have our diabetics with low EGFR. We are continuing our metformin because we know that we can continue till the EGFR is up to 30. We decide we give finrenone to such patients to reverse the EGFR. We also decide that we need to give SGLT2. The moral of the story is, my patient you're treating your diabetic patients for the last 2 years, right? With CKD. Let's say they're coming to you in CKD grade 3. Now, you as a good clinician is interested. How can I prevent the CKD grade 3 from going to grade 4? And slowly and steadily, is my patient progressing from CKD 3 to CKD 4 or progressing from 2A to 2B or 2 to 3? There is no method. In reality, in clinical science, there is no method. You keep doing EGFR, and as the EGFR goes down, you keep warning the patient and changing a prescription. But can you create a prediction analytics simulation? Can you say that 2 years from now, you would go into grade 3 or grade 4, and so you should do now so-and-so medicines and so-and-so lifestyle changes so that you don't progress? This is what this AI tool is doing, the Ergo National Laboratory at University of Chicago. I'm giving you the latest references. This is 2023. The CKD prediction can make timely nephrology intervention, medication adjustment, and lifestyle intervention before you develop end-stage renal disease. And am I talking through my head? No. These cohorts have shown real benefit. Patients who didn't have proteinuria, the predictions could be made that they could develop proteinuria and decrease in EGFR, and the benefits were there for all to see. And coming back to India, this has been approved and reviewed in the Indian Journal and Clinical Context Nephrology Journal in 2025. Last year, they did a multimodal AI where they integrated the EHR, imaging, and genetic data, and they did a scoping review, and they found that they can create a CDSS, which is a clinical decision support system, where a team can plan out and decide that 10% or 20% of my clinic patient could go into progression to renal failure. So dialysis can be planned, transplantation evaluation can be planned, and future risk stratification can be designed, and medications can be changed. Moral of the story, real-time actual precision medicine application. Let's look at another scenario. Heart failure readmission protocols in Massachusetts General Hospital, one of the most respected studies. So we all know today that diastolic heart failure, or HFpEF, right? Heart failure with preserved ejection fraction. Puneet sir has done a lot of work in that. So it's very well known that pro-BNP can be normal. There are enough cases where normal pro-BNP misguide clinicians that this person does not have heart failure and they do have heart failure. Now, if such heart failure patients are present, when they get admitted, when they will get readmitted, what would be their long-term mortality and morbidity? Trust me, there is no model, there is no clinical science to tell you all those answers, and they are important answers. And this is the model which can do that. This can integrate with your electronic healthcare system, and this kind of system can work and identify a lot of your patients, so you can do future planning and management strategies for your patient. So now I think you're understanding the beauty of the whole thing. Now let's come to proper internal medicine in the ICU and infections. Now how do we work? When we were residents and we were practicing, and we are today also, what we are treating is, let's say I'm in Hinduja Hospital, or let's say I'm in Jupiter, or I'm in KIMS. So I'm attached to Jupiter and KIMS. Now these corporate hospitals or any such big hospital, what they do is they collect the antimicrobial data from the microbiology department for the last 6 months, and they find out which antibiotics have shown resistance in the last 6 months, which bacteria are more predominant, what is their sensitivity status. And so the empirical protocols are designed, right? So we always say that you should not follow a blind empirical protocol, because when a patient walks in the ICU with an infection, or on ventilator, you have to start some empirical antibiotic before your culture reports comes, right, in a day or 2 days or 3 days. So till that time, what empirical antibiotic you give, and sometimes you lose patients because you may have given antibiotics which are resistant, and you base your your empirical antibiotic either on the guidelines that you are available on the net, or more preferentially the guidelines that your microbiology department is given based on the history. So we are practicing evidence-based medicine, but in AI we do not practice evidence-based medicine, we practice data-based medicine. So what AI says is, AI interprets that data and does not tell you that you go retrospective, but tells you that this is the antibiotic which will become resistant in the next 6 months. This is the microbial which will become more prominent as a nosocomial infection in the next 3 months. So your antibiotic prescription should be so and so, and it will vary from patient to patient, because the variables in a patient to patient vary. So at a population level, the answers are different. At an individual level, the answers are different. So you can imagine, when you do this, you actually are doing real antimicrobial stewardship. You're not giving unnecessary antibiotics, and you're giving the right antibiotic, and you're actually decreasing the mortality and morbidity. And am I talking through my head? No. This is a systematic review of machine learning in stewardship programs in 2024. And as you can see, huge. This is a huge study, a huge data. I would encourage you to go through it. And the key finding was the AI outperforms standard stewardship team decisions in leading hospitals in the US. It gave you much better outcome. Let's come to another scenario, that is a stroke prediction. I think I'll go a little fast now. So you have a patient who's got a dense, you've got a patient monoplasia or diplegia. Fine, okay, good. Now you're managing. The question is, will my dense hemiplegia go back home without dense hemiplegia? Will he get paresis? Will he become better or not? See, all relators ask this question. Even you ask yourself this question. I'm treating 10 strokes every day. Let's say, how many of my patients will recover? When will they recover? When will their morbidity come down? When they will become walkable and functional? Nobody can answer that question. No MRI, CT, or no clinical medicine can answer that question. AI can do that. AI takes multiple variables beyond your CT, MRI, hypertension, diabetes, and takes so many scores and capturing. These are scores which you cannot do statistical analysis. How can you compare a South Indian from a Gujarati from a Maharashtrian on a statistical analysis? AI can do that. You cannot do that. And am I talking through my head? The AUC under the fixed model was 0.872, but with an AI deep learning, it was 0.888, which means that the outcome was huge and the real-time predictions were successful, and you could give a better future prediction of your patient, which was not possible earlier. So I'll move fast now. This is AI and ECG. So multiple ECG analysis, multiple ECG integrations are possible. I'll share one live case of my own patient in just 30 seconds. So I had a Gujarati patient, around 45-year-old male patient, who came to me for diabetes with 300 and 400. I treated him for diabetes. He was very happy 2 months. He was very good under control. HbA1c sugars were all fine. CGM showed good data. They were happy. Then the typical scenario, why should we continue with allopathy? Allopathic medicines have got long-term side effects, blah, 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 blah. So they shifted to an Ayurvedic CARDA and Ayurvedic prescriptions. They disappeared for 6 months. When my receptions would call them, they would not pick up the phone. After 6 months, they came back to me and I asked them, why are you in my clinic now? What happened? So before that, they had a little gas problem with a little burning and a little nausea. Okay. And they went to two gastroenterologists who prescribed a scopy, which was not done, and gave antacids, and also 3 days passed in that. Then they thought, let's take a cardiologist's opinion because they read Google. So 3 cardiologists, DM cardiologists, did their ECGs, which were repeatedly normal, and they did an echo, which was normal, and they sent them back home. But by now the sugars were high. So they came back to me कि मैंने diabetes treat किया था तो वापस मेरे पास आ गए. मुझे लगा something is wrong, it is not right. I put that ECG in an AI tool, which I create, some AI tools of my own, and it picked up non-STMI. And I had a hard time convincing them that a normal ECG can look like non-STMI. Let's look into this diagnosis. Finally, I could convince them. We did an angio. We picked up 3 stents. I mean, we gave 3 stents. There were 3 blockages. And if you review the literature of NEJM AI, there is enough data to show that genuinely normal ECGs reported by the top-notch cardiologists are getting picked up as infarcts and arrhythmias by AI, not because those doctors are at fault, but because human eye has limitations. It cannot pick up wavelength changes which an AI algorithm can pick up. That is the essence of the story of AI in ECG diagnosis. Now, I think I need not talk so much about it. Personalized diabetes management, phenotype consideration. Mohan sir has spoken multiple times about Indian phenotypes behaving differently in different population. And all of you, all the esteemed personalities here have also spoken in multiple forums that patients behave very differently because of different phenotypes, the thin fat Indian, blah, 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 etc., etc. Now, we are aware of it. We know that metformin may not work in everybody. The problem is, how do you decide which patient to be given what treatment, how they respond? You cannot do that. How do you qualify that? You cannot. AI can do that based on the phenotype characteristics, which you cannot. And that has made a difference. And in South Asian population, they have shown real benefit with AI superimposition on your patient. So even if you were to use ChatGPT and impose your patient data on a well-trained ChatGPT model, I'm not recommending it. I'm just giving an example. You can get a much better outcome of your clinical decision support system than using your own knowledge alone. Now, AI for NCD surveillance in India, it was done in AIMS. It was with a collaboration with CDC, and it showed huge benefit. A lot of iterations had come out. The platform design was good, limitations were there, but this was a fantastic thing. What about AI in acute kidney injury risk in hospitalized patients? Now, this is a huge study. 7 billion US veteran records done by Google DeepMind. And let me tell you, Google DeepMind is coming up with a tremendous amount of health solutions. They will be probably swamping the entire medical fraternity field in the next 2 years. They have deployed a huge amount of models. They're spending a lot of money, and the results are fantastic. And they have picked up AKI 48 hours before clinical diagnosis. So the creatinine is normal, eGFR is normal, the blood pressure is normal, and 48 hours before you're told that this patient is going to develop AKI. Can you imagine? Now, this is not some science fiction or Bollywood or Hollywood fiction I'm talking about. This is Google DeepMind, and this is an actual data published in a prestigious journal in Nature in 2019, and it has shown a huge outcome benefit. A lot of medications have changed. Diagnosis has made a difference. Patients' mortality has fallen. So I'll move further now. I think the last slide. Yeah. Yes, sir. I'm done, sir. I'm done. Last slide. So the conclusion and take home messages is just this much. AI is there to stay. AI is a wonderful tool. It is good. It has to be deployed properly. If you deploy it properly, it is a fantastic tool. It is nothing wrong with it. Of course, Dr. Anandikesh has already told you its limitations. There is nothing like a rocket science anywhere. If you use an AI tool properly, nicely, with a proper understanding in a partnership format, see, AI is not here to replace us. We ourselves want us to be replaced by AI. You see a medical student flaunting the smartphone, going at bedside and making diagnosis without even bothering to see the patient. That is not the case. So, moral of the story is AI is fabulous, fantastic, does a lot of work. It's a very powerful tool. Use it properly and nicely. I always say this कि जब हम स्ट्रगल करते हैं, हमारे पास मोटरसाइकिल रहती है, मैं मेरी कहानी बता रहा हूँ, बाद में जब पैसे आ जाते हैं, मेरे पास तो आज भी नहीं है, कि जब आप मर्सिडीज लेते हो, ऑडी लेते हो, तो मेरी समझ में नहीं आता, लोग पीछे जाके बैठते हैं, असली मजा तो ड्राइवर लेता है जिसने खर्चा भी नहीं किया. So, the bottom line is when you're using an AI tool, please get trained and use it properly. Don't become a passenger for an AI to take the driver's seat. That is what I would like to say. Thank you very much, JK sir, for this wonderful opportunity. Thank you, all of you, for allowing me to talk, and apologize for being late. And thank you, Kulkarni sir and Aniket, for those warm, nice words of all of you. Thank you very much. I'll stop here.
Dr. Manchanda, please.
Well, so there is very little time left for question answer session. So I would like to thank all the speakers. They have done the wonderful job, and we are gradually transforming ourselves from a basic AI empowered. We are using AI at various places, not even seeing the patient, even for the documentation, for reading the even PDFs, even the large files also concentrated in the small files and everywhere. So we have narrated the uses in from the a clinical perspective, in the analytical purpose perspective, for the help for the society and the data interpretation, which could ultimately be useful for the patient as well as for the whole community, which can largely be benefited. So being updated in this field, which is new upcoming field, is very, very, I think, essential for every doctor, even at any age, whatever the practice experience one is having, accepting few tools. So I will just डॉक्टर आलोक मोदी से सिर्फ पूछूंगा कि हमारे पास सिर्फ वो 2-3 टूल बताएं जो डे टू डे प्रैक्टिस में हमारे काम करते हैं. Only name 3 tools. डॉक्टर
सर
कुलकर्णी
आप
also.
कोई भी टूल आप सर आप कोई भी स्टेथो ले लो. आपको कानों को ट्रेनिंग देनी पड़ेगी मरमर सुनने के लिए. आप चैट जीपीटी ले लो, क्लॉड ले लो. आप मैं 2 मिनट लूंगा खाली सर. क्लॉड ले लो, चैट जीपीटी ले लो, मनूस ले लो, आप परप्लेक्सिटी ले लो. दीज आर द टूल्स विच आर अवेलेबल टू ऑल ऑफ अस. आप सब्सक्रिप्शन नहीं लोगे तो दे डोंट परफॉर्म वेल. आप जब तक सही प्रॉम्प्ट नहीं दोगे ना सर, नन ऑफ द टूल विल वर्क प्रॉपर्ली. सो द बॉटम लाइन इज यू हैव टू लर्न हाउ टू प्रॉम्प्ट एआई.
Yes,
Unless you
exactly. So
prompt AI, the
that's
tool
what I
will not
wanted to
work.
listen. That we have to learn what to give a prompt command to elicit the better outcome. So, Dr. J.K. Sharma, your comments, please. Final words.
Thank you, Dr. Anil. I am really mesmerized by what I have not learned yet, but what I have listened, because learning is another important thing. We have to spend time in learning this, what these stalwarts have told us. So we will try to say inculcate the knowledge and practice it, and that is the need of the hour for everyone. So before we say thanks to everyone, you can see on the screen there is another IPF Women's Wing CME webinar. I have already put it on the screen. I think everybody can see that. And this is on the next 24th of May. We are doing every month webinar, 1 month by IPF and another month by the IPF Women's Wing. And this time the IPF Women's Wing, they will be doing on type 2 diabetes and sarcopenia in women with 2 very eminent speakers, Dr. Sunita Agrawal. She is the Director Professor of Medicine at the Maulana Azad Medical College, New Delhi, and the topic is current understanding, and next is clinical implications by Professor Swati Srivastava, who is the Governor ACP India chapter, Senior Professor, Unit Head at SMS, guest faculty Dr. Meenal Mohit, Yogita Singh, and Arati Sade. So I think if anybody has any question, then you are welcome.
Amit Kumar has asked one question
Yes, sir.
that AI is a hero on data, but if the large data and very uncoordinated one, depending upon AI, is it blunder? Our clinical oversight very important, wonderful. Absolutely, Amit, you are absolutely right. Whatever the data is going to be there, it has to be structured, and human in loop is one of the best thing. And again, please remember what Alok emphasized on his talk, that your prompt is very important. It is like telling a job to your junior. Do the prompt, write the prompt in such a way that you cover everything. Means I wrote my prompt that as a professor of medicine and head of the medicine department, I want to teach my students AI basics. Please prepare me 20 slides with 6 points, 6 bullet points each. It comes with, but rely upon that. You copy paste it, make a Word document out of it, then add your inputs to that. It will help you. Then the other point which I wanted to tell about Alok, he talked about the cardia. This is a small putty which I have just shown on your screen also. It doesn't require jelly. It doesn't require cables. You can just keep 2 fingers here, one on your left greater in internal malleus, and you will get a 6 ECG. I have diagnosed many MIs with that 6 leads. It is a very wonderful tool, especially when you are traveling, when you are in a group function, like any meeting. Suppose if somebody gets a MI during the API conference, I don't think that we have got any tools which will take the ECG within minutes like that. So, like AliveCore, there are many equipments which will help you. Now the summer season is at the peak. We are going to face a rainy season. So, lot of patients who are coming with dengue fever or other monsoon related fevers, they become really bad overnight. So in that situation, there is one application of a pulse oximeter which is called as a perfusion index. So if you have got perfusion index, and if you monitor that perfusion index for a patient which was 10.5 or a 9.5, if it is going down and down and down, that means this patient is going to worsen. The same thing you can apply a corollary to the pulse pressure. Why I am telling this? Because these are the practical points which we can do. In your TPR-BP chart, add on perfusion index and pulse pressure. If the pulse pressure is going down, the patient is going to worsen. Something very simple. And if you have got a data in Excel format, forward it to Alok and Aniket, they will come out with an excellent paper out of it. We can do a multicentric study using some simple things like this. And I'm really very sure when IPF has got so many fantastic members, we can do a lot of our publications. Thank you. That's from my side.
Okay. Thank you, sir. Thank you. Thanks a lot.
Vitul sir is here, sir. I have written a chapter for sir's book, sir. Thank you for the opportunity. He had allowed me to write a chapter. It was written by AI. So sir can tell you that it was written very fast, and because sir has accepted it, so you can give credit to AI कि उसने अच्छा ही लिखा है.
Oh, you are Shah Rukh Khan of AI.
So I wanted the comment from Professor Vitul Gupta.
So basically, I like this, symbolic similarity that it is the driver who takes all the, maja in driving Audi, and sitting behind is nothing. So basically, AI, if used intelligently, is a great assistant, assisting device. But if used for all the things, if you use it intelligently, it is going to be advantageous, and if it is not, it is going to be having adverse effects. So congratulations, Dr. J.K. Sharma, for a great session on AI by great people like Alok Modi and Dr. Kulkarni. Thank you very much.
Sir, thanks a lot. And another important information I would like to share with everyone. One, I have already shared the next webinar on 24th of May, Sunday. And I would like everyone to register for our conference on 29th and 30th of August 2026 at New Delhi. That is another thing. And spare these 2 days, you will have a wonderful academic fest. I don't know about the other type of fish that Dr. Manchanda and Dr. Puneet Khanna and Deepak Ji Pandey and Dr. Surjadeep Sen Gupta are in charge, but definitely you will have a wonderful academic fest. And the Royal College has also given us the information that they will be having their roll signing ceremony for the new fellows during our conference, and this conference is being done in association with them, and they have asked for the final scientific program, and we are trying to get it accredited from the Royal College.
Looking forward, sir.
Thank you, sir. Thank you very much. So anybody wants to say anything? Feel free
Yeah,
in another 1 or 2 minutes.
just very final, in few minutes, I just want to add that we are in the process of preparing the scientific program also. And during listening to all these talks, one suggestion from my side has been that we probably will have some input from all the leading experts of AI or about how to educate our young physicians on medical writing using AI, because a lot of issues have propped up recently about plagiarism, checkers, and use AI in publishing medical data. So a special input from leading physicians we will try to incorporate into our conference about some lecture on this particular topic, which can guide our younger physicians about how to use AI in medical writing and thesis writing. So
Sir,
we
we
will
can
keep
do a
this
live
point out.
workshop. We can do a live workshop and show live how things can go wrong and how they can be righted.
Sure, sir. Sure. Definitely, we'll keep this in mind as well.
We can
Definitely.
request people to come with their laptops and we can show it live on the screen with permission from JK sir and all of you. We can show you
Yeah.
live over there how the articles
This
are
is
written
this
and
is
how they are
innovative
written.
physician forum. Any innovation being done by any member, always welcome.
Thank you, sir.
Yeah. So I think we will have that kind of a workshop. Definitely. Yes.
So with that, we finish. And thanks everyone, all speakers, all attendees, every member of IPF. Thank you very much and good night.
Thank you, sir. Good night.
Thank you, sir.
Good
Thank you,
night.
everyone.
Good night, sir. Good night.
Good
Thank
night,
you.
Alok,
Bye.
Aniket. Thank you very
Good
much.
night, sir. Good night, everybody. Good night, JK sir. Good night, Kulkarni sir. Good night, everybody.
Good night, everybody. Good night.
Good night.